Hello, this is Dr. Bhomik. Welcome to this section of the lecture, Congenital Hypothyroidism. Uh, I'm a board certified pediatric endocrinologist, retired Colonel, United States Air Force, and professor of pediatrics and chief of the Division of Pediatric Endocrinology, University of South Alabama, College of Medicine, and from which I just retired. And this lecture is designed for the pediatric house staff, medical student, pediatric nurse practitioner, and the pediatrician who wants to sharpen their knowledge. And I would say that this part of my lecture, Congenital Hypothyroidism, is rather a complete lecture. And I have put all the slides with details description and the statement so that if you can actually gather all the slides, capture them in some way or other, I believe that all the board questions that you get in your examination will be covered. So this is the little bit the photograph or the picture of Children and Women Hospital. And I want to start with something that is really interesting to know, even then this may not have a significant impact on any of your examination or patient management, but this is something is very interesting to know. What is the fetal activity, thyroid and fetal activity? So let's look at this. By 4 to 6 weeks, there is synthesis of thyroglobulin. By about 8 to 10 weeks, trapping of iodine occurs, and 12 to 14 weeks, colloid formation has been observed, and 16 to 18 weeks, secretion of T4. So by the time the fetus is 18 weeks, is making T4. And at 20 weeks, there is maturation of hypothalamic pituitary thyroid axis with a positive negative feedback mechanism. And by mid gestation, is a pretty much thyroid is set, is developed normally. So it is also important to understand the maternal and fetal thyroid hormone relationship. By just recollecting the previous slide, you know that prior to mid gestation, the fetus appears to be dependent pretty much on maternal thyroid hormone. And approximately 30% or one-third of the maternal T4 crosses the placenta. That usually contributes about 2.7 to 5.5 milligram per TL pool of thyroid hormone. So that offers, very important, that offers a partial protection against the hypothyroidism, congenital hypothyroidism. And there is also another effort is made to protect the brain by increasing the outer ring deiodinase activities, which makes more T3. So T3 is the hormone and T4 is prohormone. So it makes it brain gets more T3 by the rapid conversion of outer ring deiodinase from T4 to T3. Immediately after birth, there is certain changes of thyroid function in the babies. It has been seen that TSH charges go up to 80 or even 100 MIU per ml within half an hour after birth. And that is contributed to the cold environment that the baby comes exposed to, stress, cord clamping, etc. And that is TSH stimulates the T4 and T3. That's the reason why T4 and T3 frequently goes to the hypothyroid range because of TSH. And the peak of this phenomenon occurs in about 24 hours. After that, it started gradually falls, and in by about a month, 4 weeks or so, it's back to normal. And this is very important to recognize because if you do the thyroid screening test in within 24 hours after birth, you are expected to see the different kind of result, and there will be different interpretation. That's why most of the nursery we like to get it after 2-3 days. And so very quick, rapid getting a thyroid test after birth is not a good idea. Premature babies we see is also a very common thing that we see. And what we see in premature baby, we see they have low total T4 and the free T4 is also somewhat low. And this is rather a protective mechanism. Uh, so against the body's external environment. So protective mechanism because body does not need that much free T4 and TSH as a premature baby. However, TSH level is usually normal. T4 gradually rises to the full term level by about 6 weeks. An incident of primary congenital hypothyroidism is actually same as term baby. For your information, it's nice to know that these are the things that crosses the placenta, and those are the iodine, antithyroid drug like methimazole and PTU. Methimazole is more so than propylthiouracil. And that's why during pregnancy, if the mother has hyperthyroidism, the OB/GYN doctor prefer using PTU than methimazole. And maternal antibodies, if mother have some antibody that might include thyroid peroxidase antibody, thyroid stimulating immunoglobulin, and thyroxine binding inhibitory immunoglobulin. These are all these things, these are IgG in nature, and so therefore they crosses the placenta. What is the relationship between thyroid hormone and the brain? And that is the essence of treating the congenital hypothyroidism as fast as possible and diagnose them as fast as possible. T4 entry in the brain is limited by blood-brain barrier. Is limited by blood-brain barrier. There is fenestration in capillary endothelium especially. That's very much prominent in pituitary and the median eminence. And that is the only reason is that to allow to get more T4 to the baby's brain for development of neurons. Another protective mechanism is choroid plexus. Cells synthesize a special type of protein which just acts as a thyroxine binding globulin, transthyretin, which facilitate the transport of T4. And there is a more conversion of T4 to T3 by activating the outer ring deiodinase, which I just mentioned before. So all these mechanisms are there to protect the baby's brain. So what is the effect of thyroid hormone on fetal brain? What is the deficiency state will result? What is the ramification of thyroid hormone deficiency for fetal brain? Let's look at them. It is very important for development of neuroblast, proliferation of neuroblast, and the migration. And it is also important for axon and dendrite growth, and it does help in differentiation of oligodendrocyte, myelination of the nerve fiber. So in other words, fetal hypothyroidism result is desynchronization of the brain development, and just simply putting as the faulty wiring system inside the brain, faulty wiring. So what's the incident of congenital hypothyroidism? Don't take this one as the simple number. This is an average, very easy to remember, 1 in 4,000, but some series it has been 1 in 2,000. The reason I put 4,000, then you can kind of remember the congenital type 1 diabetes is about 1 in 400, congenital hypothyroidism is 1 in 4,000, and roughly congenital adrenal hyperplasia 1 in 14,000. But for the purpose of your examination, these are not very important, just to give an idea. Epidemiologically also, it is seen that female preponderance 2 to 1, and 10% of all congenital hypothyroidism is due to the organification defect, and they are autosomal recessive. 10% organification defect, and this is the one they may have goiter with birth, or that goiter might appear as the baby grows. So this is goitrogenous hypothyroidism. If you have rule out iodine deficiency, then this is the one that will give you a goiter. Racial variation, the Caucasian has somewhat higher than the African American, and in different studies has shown the Asian American versus Hispanic American and so forth. But those are the things that different series will come up with different number. So what is the cause of the congenital hypothyroidism? The primary hypothyroidism clearly because of thyroid degenesis. The degenesis of thyroid includes ectopic, aplasia, hemithyroid, hemiagenesis, and all those. Of which, if you put everything together, it is the ectopic thyroid is the one more common. So among the degenesis of thyroid, ectopic thyroid is more common, and the most common ectopic position is the undersurface of the tongue, because that's where thyroid glands start developing and then migrate down to the neck. And sometimes autoimmune inborn error of thyroid hormone synthesis, that's the organification defect, that's autosomal recessive we have mentioned. And if the mother has autoimmune thyroiditis, especially, has got lots of antimicrosomal antibodies, and it might process the placenta or any antibody that might block the receptor, and therefore temporarily they may be hypothyroid. What is the other hypothyroidism? Hypothalamic or pituitary, and of which they are rare, but if they do exist, if you have a condition where the pituitary gland has not developed, pituitary hypoplasia, and the other one is septo-optic dysplasia, midline septal defect. So, as I have said, that if you just look at the ectopic hypoplasia of thyroid gland, ectopic is 60%, and hypoplasia is approximately 30%, and dishormonogenesis, and that's autosomal recessive, is about 10%. But transient primary hypothyroidism in transient, that means because of the crossing of some antibodies or other things, is about 1 in 65,000. And secondary hypothyroidism is 1 in 50 to 100,000. And TBZ deficiency is important because it's X-linked, and it's usually the boys, and they will born with low T4, However, TSH will be normal and they are not hypothyroid. So this TBZ deficiency ought to be recognized, and this is not that uncommon, 1 in 5 to 10,000. And this incident, I just gave it here just to understand the enormity of the problem, but not that you have to remember all this thing. This is one of the good diagram that I mean, diagram. This is the picture that shows the clearly a lingual thyroid. And this is another one. This is a really big one. This is lingual thyroid. So dishormonogenesis is inborn error of thyroid hormone synthesis, and the most common is the thyroid peroxidase deficiency, or also known as organification defect, and that's about 90% of the time. But the other trafficking defect and TSA's receptor abnormalities are rare. Just mention this one for academic interest, but if you remember the organification defect due to the enzyme deficiency, thyroid peroxidase, and that's the one autosomal recessive. And that is when you are counseling a mother, then if it is organification defect, there is a 25% chances of next baby to develop this problem. The transient primary hypothyroidism may occur, and that's called endemic goiter. Is people those who live in an area where there is a significant shortage of iodine in their food, called endemic goiter. If the fetus has been exposed to the iodine, exposure to the iodine and painting abdomen, in British studies have shown that by using the iodine preparation for C-section, it can give transient hypothyroidism. And maternal autoimmune antibodies, as mentioned, can process the placenta, and therefore it might block the thyroid hormone synthesis, but that's usually transient, and over the period of time, they will overcome. Maternal Graves' disease treated with PTU and tapazole, as I have mentioned, they do process the placenta, and therefore, they transiently make the baby hypothyroid, and and that's something that need to be coordinated between pediatrician and the OBGYN doctor. If the mother has been on PTU or tapazole, the pediatrician, neonatologist need to know that. In nephrotic syndrome, it might happen because of the urinary loss of iodine and iodotyrosin. Sign symptom of congenital hypothyroidism. I want to emphasize here the sign symptoms of congenital hypothyroidism initially has no sign, no symptoms. They may have no sign and no symptom. That's why this screening program has been that successful, and we have been able to protect so many babies from the brain catastrophe. If you are waiting for sign symptom to develop, there is probably enough damage has been done to the brain. But anyway, for the academic interest, we can say those things, but which I have seen is more helpful to me has been prolonged jaundice, poor temperature maintenance, constipation, feeding problem, and cold to touch. This has been retrospectively have been found, but prolonged jaundice has been very helpful. The skin mottling and umbilical hernia. We do know that African American babies have more umbilical hernia commonly, but if you see a Caucasian baby with umbilical hernia with some of the suggestive symptoms, be very suspicious that it could be congenital hypothyroidism. Macroglossia large frontinale is actually posterior frontinale is more important than the anterior frontinale, but both of them can be widely separated, and that is one of the sign of congenital hypothyroidism. Distended abdomen, hoarse cry, hypotonia, slow reflexes, and goiter less than 10% goiter is organ efficient. We don't see this kind of picture anymore. So this is one was taken from the old textbook. And this is a typical picture of a untreated baby of congenital hypothyroidism. You see umbilical hernia, and there is some jaundice. And this, the next one is actually you can see that tongue is a little bit thick tongue, protruded tongue, macroclosia, and there is a myxemi. This is what we call myxematous face, and the skin mottling of the skin. Abdominal distension with umbilical hernia. Again, this is something we don't see, and this I have taken from the old endocrine textbook. So once the screening test has come back suggestive of congenital hypothyroidism, uh, usually in this country we do the T4, and if the T4 is low, they do the TSH. However, that must not be taken as the test. It has to be verified. And for the verification, we do the blood test, and that includes a free T4 and TSH level. TBC is optional if the TBC deficiency is suspected. One can do the antibodies if mother has thyroiditis, autoimmune thyroiditis, or there is a reason to suspect the mother still have lots of antibodies. And thyroglobulin level may help to separate aplasia, hypoplasia, and ectopic gland. And thyroglobulin level is usually low in many of those areas, but is not routinely done. The other test is the thyroid sonogram, and a good sonographer will be able to detect the thyroid gland wherever it is in the neck or in the tongue. But the interpretation of this test, sonogram, has to be done by a radiologist who is very experienced in doing so. For some reason, the European have done a very good job in thyroid sonogram, but we are doing as good nowadays. But a technetium part technet 99 scan is very quick. 123 technetium part technet scan is very quick, and it can be done very same day, and then you can locate the position of thyroid gland. And so if it is under surface of the tongue, you know this is a congenital hypothyroidism which is going to be permanent, and the treatment has to be more or less lifelong. Treatment will be lifelong. And the other one can be used is iodine 123. And here is some scan. Here now you can see that this is the piece of thyroid. This is right here under surface of the tongue. Right here, the under surface of the tongue that you can see thyroid, and that makes your diagnosis. Uh, you can make the diagnosis very comfortably, and you can tell the family that look, this is where the thyroid is, and therefore this gland is not going to function, and it's not even going to come back to the normal position in the neck. So they need to have this treatment for lifelong. The treatment of congenital hypothyroidism, the recommended dose has been in the first 3 months is about 10 to 15 microgram per kg per day. But my personal experience has been when I have used 15 microgram, the baby seems to feel hypothyroid symptoms a lot, don't sleep at night. The parents feel that they are restless. However, if you can make with 10 microgram per kg per day and keep the T4 in upper normal TSH within normal limit, then I think that will be the approach. But the standard teaching is 10 to 15 microgram per kg per day, and then you have seen this like 7 to 8 microgram per 3 to 6, 6 to 12 months is 5 to 7, and so forth. So, but The most important thing is the follow-up. The most of the endocrine clinic, and first year will follow them every 2 months and will repeat the thyroid function test to adjust the dose. As you know that in first 2 years is very important for the brain development and the neuron development. Therefore, the follow-up should be very careful. First, every 2 months in the first year and every 3 months in the second year roughly has been recommended. But this all depends upon that how the thyroid function looked like previously. So goal of the treatment is to keep the serum T4 and free T4 upper half of the normal range, and TSH is suppressed to the normal range, and which is about it may take about 3 months to get that TSH down, but there is no hurry. As long as you're giving the dose, and it might even, in some cases, have been longer. The literature has shown that there is some babies with very adequate treatment, the TSH resistant phenomena, they actually last 6 months to even 1 year. Overtreatment must be avoided because one of the side effects of overtreatment is craniosynostosis, and also the baby don't gain enough weight and they are jittery. So in all circumstances, that avoid the overtreatment, and one has to make sure that they are growing normal in normal growth of development. They should be monitored and psychological test and the bone age and all this thing as a good follow-up. And the most of the time they are followed by the pediatric endocrine clinic, but a pediatrician with the consultation of a pediatric neurologist can very well do the job. And what is the prognosis? This is roughly, it has been seen that if you can start treatment within first 6 weeks, and especially if it is in the first 2 weeks, the prognosis for IQ is really, brain development is really good. And in one study, is less than 6 weeks, you get an IQ of 100. If you have delayed your treatment between 6 weeks to 3 months, is 95. 3 months to 6 months is 75. Above 6 months is 55. Just remember, this is just a figure. It is not written in the stone. It is just a figure, just to give you the enormity of and the need of diagnosis and early treatment. I cannot overemphasize that. Early diagnosis and initiation of the treatment early is of utmost importance. Neurological sequelae, that if we don't treat them really the way it should be, there is a problem with the gross and fine motor incoordination, ataxia, speech disorder, speech disorder, increase or decrease muscle tone, short attention span, ADD and ADHD. Actually, there are some study, and we begin to realize even with the good treatment and early diagnosis, there appears to be some higher incidence of ADHD in children with congenital hypothyroidism. And that goes to show that we don't understand everything. But if it is so, again, the early treatment is probably the answer. And there may be sensorineural hearing loss also.